Shall we start?
Good evening all. Welcome for the TIPS Echo session, last session on Methadone. Dr. Sunil will give a brief introduction about Dr. Anne.
So today's speaker is Dr. Anne Broderick. She has practiced hospice and palliative care since 1997, and she was a volunteer medical director at Iowa City Hospice. Then recently she stepped down as the director of palliative care and the program director for fellowship in hospice and palliative medicine at University of Iowa. Now she's going to direct hospice and palliative medicine at the University Iowa City Veteran Administration Hospital. She is a friend of Palliative India, and she is coordinating the international volunteers. And I welcome Dr. Anne for her presentation.
Thank you very much, Sunil. Before I start, good morning to people in the US, afternoon to anybody in Europe, and good evening to the people in India. I am going to put I put an ad up here. Is my PowerPoint showing up okay for everybody? I'm just going to change it to slides. I do want to let people know about this scholarship to the national conference in the US. It's for international scholars in palliative care from low or middle resource countries. Pays for their entire trip. They do need to get their own visas. Designed for people earlier in their career. The deadline is coming up. If you have any interest, please let me know and I will help facilitate. I think it's been a very helpful experience for people in the past. Well, let's go ahead and get started. And if anybody has any questions, we can discuss the scholarship later on. All right, let me just... Here we go. Okay. Dr. Sunil asked me to discuss the evidence for and against methadone in cancer and palliative care, and then to add some case studies. I think he knows that I am more comfortable in my empiricism and wanted to challenge me to be more evidence-based, and I appreciate that, Sunil, because I learned a lot in the preparation for this. I will also be very practical. I understand that some of us on the call are experienced and even expert, and some on the call are novices. I'm pitching this talk largely to the novices because I do want you to be comfortable with using methadone safely because I think it's a superb resource for our patients with pain. So my objectives are to review the evidence for methadone, which has been largely reviewed in other calls as well. Understand the role of risk stratification, that is, deciding who might be a higher risk and who might be low risk, but also examining your own tolerance for risk. I am very risk adverse. That is, I don't like to risk something bad happening unless I'm really pressed against the wall. So understanding your own risk tolerance is a key to using methadone safely. Then we will share some practical tools for methadone applicability in the Indian context for you to look at and see how it might apply. And then I hope that you come away from this call recognizing the need for collaboration with colleagues during this implementation phase. I myself never write for methadone without a conversation with one other colleague, and it might be a pharmacist, it might be it might be another physician or nurse practitioner in my context. Okay. The other thing that I think is worth saying is that the US environment from which most of this data comes is very different. And most of the evidence comes from where methadone has been used. In my environment, an emergency doctor can come at any time. An emergency vehicle can come within 8 minutes to my house, within 20 minutes in rural areas. So very important that we understand that the context of the US, Europe, Australia, and Canada are very different than India. So, of course, we always go to Cochrane reviews when we're thinking about methadone, and the Cochrane review has occurred 3 times, and most recently in 2017. 17 studies were reviewed in this update, but 11 were excluded because they didn't meet the criteria that Cochrane uses. Even the 6 studies that they thought were methodologically sound didn't have similar enough methodology to be able to combine them. But there was a single study that showed pain reduction of 20% for both morphine and methadone. So it didn't show superiority of methadone over morphine, which might surprise some of the empiricists in the group. I wanted to share next a risk score that has been validated in the US, because I think this might help get us started or help get you started in India. I include myself because I feel so much kinship with all of you. So I guess the question is, how could US data help you choose low-risk patients to start methadone? So let's look at this study. It was done in a tertiary care center in the US. And so they were trying to build a risk score for QT prolongation. One of the dreaded complications of methadone, as you've heard many times, is that the QT interval prolongs so much to cause torsade de pointes. And the question was, could we develop a risk score? So the risk score for QT prolongation was developed using 900 patients who were admitted to the ICU. And in our ICUs, as in most ICUs, they will have continuous each ECG monitoring. So multivariate analysis then demonstrated some independent variables, and then this risk score was validated on 300 subsequent patients who came into the ICU. So here's the risk score that you've already seen from Kushal's talk, but I thought some things bear repeating. So here's a risk score for QT prolongation. And surprisingly enough, we shouldn't be surprised by what are the risk scores. The age greater than 68, females have a longer QT interval naturally, and so being a female would be greater risk. A loop diuretic, potassium that's less than 3.5, a QTC, that's the QT corrected interval greater than 450 milliseconds. 2 or more QT prolonging drugs gives you 3 points. Sepsis gives you 3 points. Heart failure gives you 3 points. And 1 QT prolonging drug gives you 3 points. So if you have 2 or more QT prolonging drugs, you get 6 points. 1 for having 1 QT prolonging drug and another 3 points for having 2 or more. So a low risk person is somebody who has 7 points, moderate 7 to 10, and high is a greater than 11. So I could imagine using this as I was initiating methadone to give me some more confidence that methadone would be safe in a patient that I was planning to either rotate to methadone or initiate methadone. So let's go to a case because I think it's helpful to do it that way. Mr. Sanjay is a 51-year-old with squamous cell cancer of the tongue. He's finished 30 fractions of radiation with concurrent chemotherapy, which means that he's in active care of an oncologist and a radiotherapist. The intent is curative, that is, they're working towards cure, not just to control the cancer. He can't swallow because the pain is so great. He has no yeast visible on his palate. I look for that because I want to make sure that's not what's causing the pain. He has grade 3 mucositis, which means that he can only take liquid alimentation or food. He's taking quite a bit of morphine, 40 milligrams, 6 times a day. He still rates his pain very high, describes it as shooting and burning. Morphine takes the edge off. Oh, interesting. His daughter is an RN and he's on no medications other than the morphine and the bisacodyl. Are there any questions about this case? Or shall we go on? Okay, hearing no questions. Should we use methadone? Well, there's been a study about head and neck cancer comparing methadone to fentanyl patch. I know that fentanyl patch is not readily available in India, but it is a good marker for just a pure opiate. So it's a good comparison for us between methadone and fentanyl. So the initial doses for interest's sake were fentanyl 12 microgram patch with breakthrough given either sublingually or intranasally, or methadone 2.5 milligrams twice a day with fentanyl also used as breakthrough. And pain scores were significantly better with methadone, even as early as 1 week. This would match my empirical experience where we use methadone in head and neck cancers very readily. They tend to do quite well in this setting. So that meets my empirical sense as well. This is a group that I selectively use methadone on quite a bit. But is he a candidate for methadone? Well, what's his risk score? So let's head back to the risk analysis. Is his age greater than 68? No. He's a man. He's not on any medications. Uh-oh, we don't know what his serum potassium is. So let's just give him 2 points just because we don't know what it is. Oh, we don't have an EKG either. Let's give him those 2 points. He's on no other drugs. He's not septic, doesn't have heart failure. So his score is 4, which brings him to, he's now a low risk. All right, so far, at least from this risk model, that Mr. Sanjay is a low risk. Then I share with you the checklist that we use at the University of Iowa. This is largely from the references down there, and I'll also show you where it is as well. This comes from a consensus statement that included people from the Heart Rhythm Society, from Palliative Care, and from pain in an effort to make methadone safer in this country in the face of many, many accidental deaths. Okay, so we're back to the checklist. In my experience, I ask for about alcohol. I make no assumptions that somebody, even with a gastric tube, isn't drinking. I've been startled at how many people might put alcohol down a gastric tube. And what other substances might be used. We work very hard to get a very complete medication list. including things that are over the counter in your context. This might also be the Ayurvedic medicines that nobody thinks to share as well. So then the second piece is talking about the IO experience. I work hard with the oncologist to talk about what I'm planning to do with methadone, and will this be a problem given the other medicines that might be started and that might be inducers or inhibitors of the P450 system that metabolizes methadone and other drugs. So very important to create a relationship with the oncologist. Interesting that Naveen said that typically he wouldn't use methadone if the patient is still, I think you said this, Naveen, I'm not positive, that he wouldn't use it if the patient was still getting active therapy. And I think that really depends on the relationship with your oncologist. Sometimes, in my case, they're so desperate to get pain control that they're willing to do just about anything to allow patients to get better pain control. All right. In our context, we can easily check a potassium and a magnesium. We don't typically check calcium. I noticed Naveen spoke about that, and it is sort of related to the loss of potassium. So vomiting, diarrhea, I don't know if I just made that mark. We also ask about structural heart disease, whether they've had any valvular disease, whether they've had any heart surgery. A family history of sudden death. Have people died while playing soccer, basketball? Have there been sudden deaths or unexplained fainting or syncope? And we pretty much require a reliable caregiver, though if the patient, him or herself, is reliable, that might not be necessary. And the next issue is this a patient and family that we can educate about the risks, educate the need to stay in touch, not to start any other medications without a phone call? Can we build a relationship that way? We do typically get an EKG, though I'll talk about recommendations for home patients. And has there been a history of non-adherence or self-adjusting of medications? All of these things are in our checklist. Are there any questions about this checklist? I know that we talked about doing this last time. Okay. Is anybody there? Am I talking? All right. Okay. Well, those who know me know that I would then do a physical exam helping me. This isn't, I look for the size of the pupils so that I know how much opiates they have on board now. Check the oropharynx, especially for thrush, because I'm concerned that fluconazole, which is will interact with methadone, might be started. I'm checking the heart for murmurs, bradycardia, and irregular rhythm, and abdominal exam for bowel sounds. Those are my highlights. Obviously, I do a more thorough physical exam often. And the biggest reason I do a physical is that when the daughter, who's an RN, calls me, I want to be able to put her calls in context. The use of methadone means that you're far more in touch with patients and families, and you're going to be using telephone medicine more often than sometimes you're used to. I just remind you that there are drugs that we used, at least I used when I was at, or saw being used when I was at Palliative, and there they are. Okay, so now we're going to convert, and I think there's data to support which way we convert. Let's start with the one that Naveen used, which is called the 3-day switch. I've never used this, and And then I also want to show you, so this is a conversion of lowering the morphine and increasing the methadone over 3 days. The next method is methadone as a co-analgesic. That is, you're using it as a long-acting source of pain control. This is probably close to what I do. A third method is proposed by Virtual Hospice of Canada, start low and go slow. And third or fourth is a modified Morley-Macon, which adjusts for age. Okay, to start with the 3-day switch, and let me just say that head-to-head, these methods have not been evaluated. So what I'm going to share with you is consensus data from the pain field and from the hospice and palliative care field from the United States. Again, something might be a starting point for Indian palliative care practitioners to develop your own consensus statement. Okay, so this is the conversion ratio which most people use. It's got many adaptations. When I started using it, it was called the MD Anderson method, but I think this is what's typically used. I'm just leaving it there for reference. And I think what is an interesting piece of data, and I will thank Dr. Sunil for sending me to the data for this. A large academic medical center in San Diego, California, Edmonds et al. In 2017 published data about the methadone initial and final dose during hospitalization. That is, they followed a patient's for an average, 98 patients for an average of 1 week, and saw what the initial dose was and the final dose. So this was a retrospective chart review of 98 hospitalized patients for whom methadone was initiated. After the week, the average final daily methadone dose was 18.1 milligrams with a large span and range, plus or minus 16.7. So this was after an average of 1 week. 2/3 of the patient received less than the target doses as calculated by Eperk and Friedman methods, which are variations on the method that I just showed you. So this was a surprise to me because this seems like a very low, very moderate dose of methadone, much lower than I would typically see in my own practice, suggesting to me that maybe our methadone doses for pain don't need to be as high as we thought in the 90s and early 2000s. And indeed, the modified Morley-Macon suggests that we should be starting at much lower doses. And for patients who are on less than 60 milligrams of daily dose of morphine, we should be starting at a very low dose of 2.5, 3 times a day. We should change our practice of our dosing depending on age and how high the dose is of methadone. All right, and these are all sitting here for your reference and we'll come back to you in an email, but let's go on and talk about the consensus recommendations, because at the end we will probably never get a head-to-head comparison of all the methods of rotating morphine to methadone, but do have these consensus recommendations. So Dr. Suresh did mention these consensus, and even mentioned that people were mad about these consensus recommendations. And I think they do fly in the face of our practices in the 90s and 2000s. So here they are. The first parameter is whether one should get an ECG. And the American Pain Society, largely dealing with people who do not have cancer or terminal illnesses, say that it should be prior to initiation in any patient and periodically thereafter. They hedge a little bit, but then come back to this relatively strong recommendation. And in the document, which is we sent out a couple days ago, you'll see exactly what those recommendations are. The Hospice and Palliative Care Consensus Group has not fully published their recommendations, but did send it out in a document published by the American Hospice and Palliative Care Association, and their recommendation is less prescriptive. It says that one should use clinical judgment, especially in the home care patient, on whether to use an ECG, and it should be based on goals. That is, so I think that's very reasonable. The rest is what was most startling to me. In an opiate naive patient or somebody on less than 60 milligrams a day of morphine, do not exceed 7.5 milligrams of methadone in the daily dose. And for all the these other parameters, the Hospice and Palliative Care Consensus Group agreed with the American Pain Society. I'm sure there are people who don't agree, and again, these are all built on safety. So rotating from other opiates, don't ever exceed 30 to 40 milligrams a day, even if the rotation or equal analgesic table tells you it's 60 milligrams a day. Don't do it. Start at 30 to 40 a day in divided doses. And the ceiling for the initial dose is 30 to 40. The adjustment interval is every 5 to 7 days. And I know I'm giving you a different opinion than others have given you, but I'm wanting to share this consensus information. And this is based largely on the long half-life. The half-life can be 24 hours. It can even be 120 hours. So quite variable. And I think the part that is, if all of you go back and look at Cashel's slides, which I would recommend, I did it over the last week, the most exciting part of all this is that we are learning more and more about pharmacogenetics. We know that things are going to be metabolized differently in India. We don't have a study of Indian heritage Americans to provide for this new Indian experience. So I think since we know so little about the pharmacodynamics, it's important that this adjustment interval be on the conservative side. And they will also be extremely conservative on how much you adjust every 5 to 7 days, saying no more than 5 a day initially, then 10 a day as you establish that the patient tolerates. Somebody's telling me to hurry up. We'll do. Okay. So here's the 3-day method. 240 milligrams is equal to 30 milligrams of methadone. On day 1, the daily morphine is reduced by 1/3 and given every 4 hours. So this would mean 160 milligrams divided by 6. So 25 milligrams of morphine is given every 4 hours. And the methadone is 1/3 of the target methadone is given in that first day. Then the second day, the daily morphine dose is further reduced by 1/3 and given every 4 hours. And 2/3 of the target methadone dose is given every 8. Day 3, morphine is discontinued and methadone 10 milligrams every 3 hours is given. This is acceptable because it's 30 or less. All right. So what about using methadone as a long-acting or co-analgesic? So you could just start low-dose methadone and usually in a non-opiate naive patient. Breakthrough dose of morphine can be given every 4 hours. So you might give 1 to 2 milligrams of methadone every 8 hours and continue morphine as needed. This is a very safe and a technique that I use fairly frequently, and there's data to support its use. This is a retrospective cohort study, followed 146 patients for 60 days. 49% of the patients, or half of the patients, had a greater than 30% reduction in pain, with the addition of a median daily dose of methadone that ranged as low as 3 milligrams and as high as 30 milligrams. So it was a limited study, but there were no adverse events. So using it, just a whisper of methadone 3 times a day, every 8 hours, would be a very useful way to start methadone as well. So Virtual Hospice of Canada has started a very strong education program, and it's available online if you Google them. They have said start low and go slow, and I think Dr. Naveen said the same thing, safety first. So this method, you might start as little as 1 milligram for frail elderly patients or 2.5 milligrams every 8 hours. You use morphine for breakthrough. Doesn't matter that the patient was on very high morphine doses before, still start the same low dose of morphine. Adjust every 5 to 7 days based on morphine use. And the American Pain Society recommends increases that are very small compared to what I would do, but I'm going to change my practice. Increases of 5 a day. The Morley-Macon method would take Mr. Sanjay and give him would give him 12 milligrams a day of methadone, so less than the initial equal analgesic table. And then we would monitor fairly closely with regular phone calls from the palliative care team. No adjustments in methadone for 5 to 7 days, and instructions repeated each time to him and his daughter to call for palpitation, syncope, seizures, and bradycardia, remembering that torsade arises from bradycardia, not tachycardia. Okay, 5 more minutes. Okay, let's shoot through these and then we'll be able to have our discussion. 60-year-old woman with end-stage cervical cancer. She's not getting out of bed. Her family feeds her small amounts of oats at regular intervals. When she's awake, she has pain in her pelvis that shoots to her legs. Morphine sedates the patient, but doesn't seem to help with the pain. Is she a candidate for methadone? What do we do if she stops swallowing? Okay, so her daily dose is 120 milligrams. The conservative start low, go slow method would be 2.5 milligrams every 8 hours with morphine given as breakthrough. The usual method would give her 15 milligrams a day of methadone. The modified Morley-Macon would give her 12 milligrams of methadone. So you can see there's quite a range. I think you'll be fine with any of those, but I think you can hear would probably err on the conservative side. We'd still be monitoring. When she's no longer able to swallow, we'd convert her to a methadone liquid, which is absorbed partially in the oral mucosa. And then finally, our last patient is the 38-year-old with osteosarcoma. He's largely at home. He takes morphine 10 milligrams every 4 hours during the day, good results, but can't sleep at night. He gets a shooting pain in his leg that starts around 2 a.m. and doubling his nighttime dose of morphine has not been helpful. So this is where I would use methadone as a co-analgesic as described in that literature, methadone 2.5 at night. Can you switch methadone? So you say you get methadone and then you think, oh, I want to go back to the other stuff. I've included an old case presentation by Eric Promer, included in your must-reads references. And it turns out that it's not usually very successful to switch from methadone back. And turns out that 12 out of 13 of those rotated off methadone needed to rotate back to methadone. If you're attempting to rotate off, consider other NMDA antagonists such as ketamine or nerve blocks. So quickly, let me say that this study is very helpful in talking about risk assessment, prevention, and management, and I love this one. I'm trying to give you just this. Eric Promer article was most helpful because he describes how methadone works in great clarity. And then finally, I think this number 3 is going to be useful as you, as palliative care, Indian palliative care practitioners, work to build a consensus statement that works for India. And my summary is know yourself and your own risk tolerance. Use tools and a prescribing partner to gain confidence. Your patients are going to love you because you're calling them every 3 days, and I believe that their pain will be diminished simply knowing that their palliative care team is being so attentive. This is certainly my experience. They feel less anxious, and that lack of anxiety translate into better pain control. And then thank you, Dr. Sunil. Follow the data, and because I think prescribing practices are changing. Okay. Sorry that I had to rush through those last. There are some other references that are very, that I've mentioned already. And here's where I was last week. Yosemite Park, National Park, Mirror Lake. All right, I'm ready for questions, sorry, or I'm ready for discussion.
Discussion.
And will you please unshare the screen? Yeah.
Oh, can I unshare the screen?
Yeah. Please close the screen.
All right, I'm trying.
Yes. So thank you. I think we got some answers like checklist and things from Dr. Van's presentation. The session is open for discussion now. Anybody has? Yeah. John.
Dr. Ann, pardon me, you spoke about co-analgesia and using the long-acting methadone for doing that. All of us read about things like, oh, we use long-acting morphine and then short-acting morphine for breakthrough. Okay, we read about that all the time. In some settings, there isn't access to long-acting morphine, right? So as you say that about the co-analgesic, it strikes me as this is sort of like using long-acting morphine if it were available, except if it's not available, you're using the methadone as the long-acting component of the pain relief, and then PRN, short-acting morphine as the breakthrough pain. Am I right when you describe that?
Yes, am I muted? No. I think methadone will act as the long-acting opiate in the context. And I think that might be for the novice, the way they're going to start using methadone is using it in a low-risk patient at night on a regular basis. When I visited the Palliative inpatient unit, I often saw that they doubled up on the morphine at night at 10 o'clock. This might be an option in the appropriate patient to simply give a low dose of methadone to that patient instead. Very safe, would be a very safe use of methadone. How did people do with the calculations? Did anybody, I know that you didn't get the cases very early. How did people do the calculations on the worksheet that we sent ahead? Dr. John, you didn't. I can tell by the smile on your face. Okay, never mind. I'm looking at all of you looking sheepish, so I think that means nobody did. That's fine. I think what I'd also like to say is that the methadone calculation should always be done with somebody else. I'm certainly happy to be one of those people that helps with calculations from afar. Obviously, I can't do it in real time, but my email is available to everybody. Is Dr. Naveen on the call?
He has not joined today.
I'm sorry, he's not here?
No,
I
no.
can't see. Okay.
Yes, again.
I would second what Dr. Ann just said about talking to your colleagues when you start out doing this prescribing. I've been doing this for 10 years, and I don't necessarily, I still talk to my colleagues, and my colleagues still talk to me. We don't need to have our hands held yet. At the same time, those of us who've been doing this for a long time still talk to our colleagues. It's not a weakness. It's not being unskilled. It's putting safety and good patient care first. So I second what Dr. Ann said.
So I think I'll ask a question of the group. What barriers do you see to starting methadone at this time? Let's say other than availability. Dr. Sunil, what do you think? What barriers do you feel? What's stopping you from using methadone? What's giving you a stomach ache?
It's the lack of experience, because I have not even seen this, but hopefully it will get written shortly. So maybe the experience is the one, and drug interactions, which I think is a problem. So it has to be used carefully.
I agree, and that's why sometimes starting by simply using that Tisdale risk assessment and deciding that you're just going to use it with a few patients who are low risk and just at night. So taking small steps to use methadone potentially just as a co-analgesic to start before you do big interventions or converting all the methadone. There's some comments in the chat. What's my experience of rotating methadone to other opiates? truth is that once I get people on methadone, I rarely change them back. And I think the data was clear from Promer's article that once people got rotated to methadone and tried to rotate to other opiates, it was not successful. So once on methadone, I have tapered people off methadone with time, very slowly and with time, because they don't have any pain anymore. But if somebody has pain, I'm usually not successful getting them from methadone to another opiate. And the question of how do we prevent cumulative toxicity, and the way you prevent stacking or layering, as Cashel called it, is to not adjust methadone any sooner than 5 to 7 days. Okay, so I think that answers that. As long as you don't increase the methadone too soon. Dr. Mary said what's keeping her from starting methadone is lack of familiarity. And I think that's why you partner with somebody. You start low and go slow. You might just start by using 2.5 milligrams of methadone in a low-risk patient in a palliative care unit to get your familiarity. We all did this, and we all talked to our colleagues. So I think unfamiliarity is what's probably holding a lot of people back, and that's one of the reasons that this is why we're doing what we're doing. Let me just put another, I know I'm putting ads out, but for the month of July, Dr. Srini Cherry is coming from Canada to spend a month at TIPS. He helped develop the virtual Hospice of Canada methadone talk, and so you will have resources. He's hoping to do some training lectures while he's there. So there's Cashel saying ketamine is another superb NMDA antagonist, and that's what we might use if methadone fails. So Vidya said she's worried about follow-up, and I would agree that you need, and again, everything's about these early implementation phase. In these early days, as you gain experience, you're going to want either yourself or a trusted nurse, pharmacist, to be calling the patients on a regular basis. And you won't select a patient to get methadone unless they can be followed up regularly, that you can't be followed up regularly. I think our typical practice is to be in touch every 3 to 7 days. More questions?
And I have a question.
Yeah.
So you talked about 3-day switch, and also when we need to start methadone in elderly, we have to start it with 1 or 2 milligram. That's what I thought you have told. So is it different between the adult and elderly, the dosage of methadone?
When I did the start low and go slow method, we typically do 1 milligram every 8 hours for the frail and elders, and 2.5, 1 milligram Q8 hours for the frail elders, and 2.5 for regular adults. Does that answer your question?
Yeah. Thank you.
Dr. Andrews, another question. If telephone follow-up is difficult, can the patients be seen every 7 days? Would this be safe?
Yes. Is this safe? Everything's relative. I think I would have them find out if they have ways to be in touch. But yes, if telephone is not possible, then every 7 days would be very prudent. Yes, the answer is yes. In the early days of methadone in India, you might select only people that you can be in touch with, but every 7 days is very prudent follow-up. At the end of the day, we don't want to limit availability of this useful medication to patients. So I think it's important if your unfamiliarity or your own personal concern is keeping you from using methadone, it's time that we banded together and started using it. And I do believe that there are international palliative care physicians and internal experts who have used methadone who can help guide us. And I believe that with time, you might decide not to start at this very low level in young, low-risk patients, but initially this may be where you want to start to gain the experience over the next 1 to 2 years so that you can write a consensus statement. Sorry, sounded like somebody else. Yep, can't hear you. I think you're muted.
I need 2 minutes before moving on to further discussion. So now we are going to share a questionnaire which we have given for pre-test. Now it will be shared, and I request all of you to just go through and mark it properly. So it will take only 2-3 minutes. So there are only 5 questions. So we will now share the screen. So everybody please fill it up and please. So I hope everybody can see the screen. Please click the correct answer. And also, while you finish all the 5 questions, submit the answer. So everybody please fill the questionnaire. Only 1 minute 50 seconds remains. Only 9 of you have attended. Yeah, increasing. Now it's 14. 17. Yeah, okay. I think all of you did. Thank you. Now we can continue with the discussion. So, Biju, do you want to ask any question?
What would be, what are next steps, Sunil, for a checklist for India?
I think one that you have shared, and it can be sent to the participants of this group and the local experts from India, so that I don't know whether any modification is needed, and if needed, we can do it together, and then will be sent to all of them, all the participants.
Okay.
And is it possible to discuss this questionnaire? I don't know the answers.
Well, I think I got one of them wrong myself. So is there some way of bringing up the questionnaire again or not? I don't remember. I don't know the answer.
Yeah. I can share the screen.
Okay. So I'm pretty sure I got one wrong at least. So.
So can you see this, Anne?
I can see something, but it doesn't look like a questionnaire yet.
Okay, I will read. First question is, all of the following statements are true about pharmacological properties of methadone, except first choice is safe in renal failure. Second, broad spectrum of action. Third, easy to use. Fourth, no ceiling effect. Fifth, oral route of administration.
For me, the easy to use was the incorrect one.
Yeah, okay.
Okay.
Thank you. Next question. All of the following statements are true about cardiac effects of methadone, except concurrent administration of drugs causing QT interval prolongation could lead to cardiac adverse effect. B. QTC more than 400 milliseconds is contraindication for using methadone.
That's the wrong one, because the contraindication is 500 milliseconds.
Okay, thank you. Next, all of the following statements are true about when to use methadone, except opioid tolerance, opioid neurotoxicity, opioid addiction, renal failure, malignant bone pain.
I couldn't figure out the right answer on that one, because methadone would be used in all of those situations.
I agree.
It happens that methadone addiction in this country is only, opiate addiction is only managed by certain people, not all people, but it is used for all of them. So I put opiate addiction, but there is no correct answer to that question.
Okay, I will discuss the answer with the concerned person who made this questionnaire, and will send you the explanation.
Okay.
Fourth question. Oral morphine to methadone conversion ratio for a patient who is currently on 40 milligram morphine every 4 hours is 2:1, 4:1, 8:1.
So that's a sort of a trick. That's a trick question as well. So for the usual conversion ratio, it would be 8:1.
Yeah.
But the modified Morley-Macon would require an age, and it would either be 10:1 or 20:1, which I think in the initial Indian context, I would use 20:1 or 10:1 over an 8:1, except for novices, which, so, ooh, all right, it's out of focus, but I see it.
Okay. Next, last question. All of the following drugs, when administered along with methadone, can cause methadone toxicity, except cetirizine, atorvastatin, clarithromycin, dexamethasone, fluconazole.
Atorvastatin, I hope. Cashel, are you on the line?
I am on the line. So, you know, atorvastatin won't cause methadone toxicity, but dexamethasone, it actually induces the breakdown of methadone. So it would lower levels of methadone, and it may have a small impact on pain control, but it wouldn't raise the levels. And so raising levels is where we get worried about methadone toxicity. So for that question, I think that atorvastatin and dexamethasone would be okay answers. Atorvastatin does inhibit some of the CYPs a little bit, but it's not like simvastatin, so we don't worry about it as much.
Okay, so probably the answer they were going for was atorvastatin, but dexamethasone lowers levels rather than.
I can't tell if they were going for atorvastatin or dexamethasone.
Okay. All righty. Okay. Does that help? I know somebody on the chat asked for us to go through Dr. Meka. I hope that's helpful. I hope it's helpful when the professor doesn't get them all right either. Or can't figure out the right answer.
Thanks, ma'am. Thank you.
All right.
Any more questions?
Well, please use my email. And again, if we can be helpful, I know Dr. John's interested in being helpful, and Dr. Cherry will be there at the end of the week.
If there is no question, I think we will stop now. But before stopping, our next session on ECHO will be on rehabilitation as a part of chronic pain management. So that will be, we will start this session on 19th of July. And it will be by Dr. Nandakumar, who is a well-known physiatrist and has very much experience in working in palliative care setting. So I think that will be a very useful session. And I request all of you to join for that session on 19th July. It will be on Wednesdays. So these sessions, the coming sessions will be on Wednesdays from 3:30 to 5 p.m. The learning points and the articles will be shared by you. I think we have already shared one article with you, which was sent by Dr. Ann. And now I will send the explanations of the questions also.
Excellent. Thank you, Dr. Sunil. I have to start my work day. Okay. Bye-bye.
Thank you all.